great question. So most recently at ASCO of this June, we saw the updated 5-year follow-up analysis from the CARTITUDE-1 trial, which was the initial trial leading to the approval of cilta-cel in heavily pretreated multiple myeloma patients who had received 4 or more prior lines of therapy. So long-term follow-up of CARTITUDE-1 trial showed that 1/3 of patients remained treatment and progression-free for the last 5 years after cilta-cel infusion without any maintenance or subsequent therapy following the infusion, which in my opinion is pretty impressive. So cilta-cel therapy has now moved into the earlier lines of therapy based on the randomized phase 3 CARTITUDE-4 trial, which basically compared cilta-cel versus standard of care regimens in patients with 1 to 3 prior lines of therapy, basically in patients that had received 1 to 3 prior lines of therapy. So cilta-cel was associated with a significantly higher overall response rate and progression-free survival. In addition, CARTITUDE-4 reported a dramatic improvement in quality of life of these patients, which is pretty important. Cilta-cel also showed improved progression-free and overall survival compared to standard of care regimens across multiple subgroups in the CARTITUDE-4 trial, including patients with high-risk cytogenetics, extramedullary disease, and those treated in the second-line setting or beyond. So as of April of 2024, cilta-cel is now approved after 1 prior line of therapy, including a proteasome inhibitor and lenalidomide refractoriness. So I would say overall the most compelling argument for earlier line cilta-cel use is its remarkable efficacy. However, there are several reasons to basically advise caution with early cilta-cel use. So as we know, CAR T-cell therapies can be associated with serious risks such as cytokine release syndrome, immune effector cell-associated neurotoxicity syndrome, and delayed neurotoxicity, which includes cranial nerve palsies and Parkinsonism, as well as high-grade infections, which actually represent the most common cause of non-relapse mortality after CAR T-cell therapy. Other toxicities with cilta-cel, which are less common, are, for example, a recently characterized syndrome of immune effector cell-associated enterocolitis that presents as delayed onset diarrhea with negative infectious workup, and most recently, the risk of second primary malignancies, such as T-cell lymphomas following cilta-cel in multiple myeloma, has also gained increasing attention. I personally believe that the potential benefits of earlier CAR T-cell therapy use are undeniable because CAR T offers deep and durable responses. Although, of course, careful consideration of toxicity, cost, and accessibility is important, the robust evidence basically strongly supports integrating CAR T-cell therapy into earlier lines of myeloma therapy. Of course, the risks and benefits of cilta-cel should be carefully weighted when considering its early use, taking, of course, into account the individual patient's clinical profile. Some factors such as frailty, aggressive disease kinetics, lack of a dedicated caregiver, or geographical limitations may preclude some patients from receiving cilta-cel.